spinals, epidurals, and other mythical beasts because I think that in a lot of situations, nurses on the floor really kind of think of this epidural as kind of this mythical thing. Like anything that goes wrong with the patient on the floor with an epidural is the epidural's fault. That's a generalization that I make, and I'm sure it's not true, but that's why I entitled it that. And you'll see some pictures of mythical beasts as we go along too. I started, what I want this to be like is a dialogue. So if you have questions for me, anytime, stop me, and I'll answer any questions that you have. But this is going to be kind of simplistic at first, so if you all have a good understanding of spinals, epidurals, and things like that, I apologize, but I think in order to really kind of convey an understanding of these things, we have to kind of get basic first. So with that being said, the first thing that we kind of have to talk about is just some basic anatomy. And when we're talking about spinals and epidurals, we're talking about the back. Now, at first glance, you might think the back is a pretty simplistic structure. In actuality, that's completely not true. It's a very intricate structure: bones, muscles, tendons, ligaments, fascia, those types of things. And when we're talking about spinals and epidurals specifically, we are concerned with the spine. And the spine is basically the backbone of the central nervous system, and it's composed of 31 vertebrae. And these vertebrae basically house the spinal cord. And we'll talk about that in just a minute. But there are 31 of them. There are 8 cervical in the neck region, 12 thoracic in the middle back, 5 lumbar, 5 sacral, and then 1 coccygeal. And to the, actually, this is just a typical vertebra there, and this is anterior, this is posterior. Basically, what I want you to pay in mind is the foramen there, which is what the spinal cord runs through. So the spinal cord is basically just an extension of the brain that extends through that foramen, and it's surrounded by blood, cerebrospinal fluid, veins, arteries, things like that, and it's also surrounded by the meninges. And people think, well, what are the meninges? Well, the meninges are the system of membranes that basically surround the entire central nervous system, including the brain. And from outer to most inner, it's the dura, the arachnoid, and the pia. The pia is what lies directly on top of the central nervous system. And this is probably a really important picture here. Hopefully you can see the blow up here. This is a vertebra. This is the spinal cord, and this blow up here is basically the difference between a spinal and an epidural. The epidural is a catheter which goes into this white space, which is just outside the dura. And so that's our goal, is to get a catheter in that white area. The red kind of area is the dura. And what we're trying to do with the spinal is we try to puncture that dura, and we inject a local anesthetic into this area, and that local anesthetic almost immediately gets access to the central nervous system. The difference between we'll talk about the differences between the spinal and the epidural, but just glancing at this, you can tell that the medication that we give through an epidural has to diffuse through this area in order to get to the central nervous system, whereas with the spinal, we are basically injecting the local anesthetic right next to it. So that's a pretty important slide. Oh, these are some of the mythical beasts. You'll have to put up with it. This is my horse, which is in Washington State. Houston is what he goes by. His proper name is Keeping It Simple, which I think that's what we're going to try to do today. So what are we talking about when we talk about spinals and epidurals? Well, we're talking about regional anesthesia, and it's a subcategory of regional anesthesia that we refer to as neuraxial block. And we call it neuraxial block because referring to the brain, axial referring to the axis of the spine. So that's the subset of regional anesthesia that we're talking about. And why do we use these guys? Well, we use them for surgical anesthesia as the sole anesthetic for surgical anesthesia. We use it as an adjunct or an additive to general anesthesia. We use both modes for obstetric pain, and more and more often we're using these modes of anesthesia for controlling post-op pain, and they can be quite effective. And we've kind of already talked about the first two there, just going back to the slide where the catheter goes and where the anesthetic goes with the spinal. Why? Does anybody know why? With epidural anesthesia, we can do it anywhere along the neuroaxis. You're probably not going to do it in the cervical area because that would be kind of silly, but why would we not do spinal anesthesia anywhere along the axis of the spine. Why is that located? Why do we just do spinal anesthesia in the lumbar area? Anybody know?
Cause respiratory compromise?
It could, but the spine ends at about L1, L2. And if you go any higher than that, you can actually put a needle right into the spinal cord. And we don't want to do that. That's kind of a big deal. So that's why we don't do that. So just to kind of reiterate, spinal anesthesia is limited to the lumbar area. Epidural anesthesia can basically occur anywhere along the spine. What is the difference? Well, in generalities, a spinal takes much less time to perform. It's much more comfortable for patients than an epidural. It's a smaller needle. It requires much less local anesthetic because we're injecting it right into the space that I showed you on the slide. It produces fairly significant motor and sensory block. Most patients can't move their legs. That's the last thing to go, though, so don't necessarily think that if a patient can move his or her legs, that it's not working. Sensory is the first thing to go, motor is the last thing, and sometimes motor doesn't go at all. And there's also a clearly defined endpoint. Once I get some CSF, which is that clear fluid that comes back, I know I'm in the right spot. When we're talking about epidural anesthesia, we have some advantages of it over spinal anesthesia. There's a decreased risk for post-dural puncture headache. And that's because we're not actually puncturing the dura, at least not intentionally. And we'll talk about what happens when that happens too. It's easier to avoid hypotension with an epidural because we have a catheter in there that is just giving medication that I control, how much I give, the rate, the concentration, those types of things. So it's much more controllable given just the nature of what is in place. And the nice thing about epidural anesthesia is the last point there is that we put a catheter in there that we can leave in for as long as we need to control a person's pain. That's my, I think she mentioned Coleman. This is Coleman. Coleman's a charcoal Labrador. This is actually in Alaska. And if you can see the mountains in the back, that's the Chugach mountain range, which is just beautiful. He's in Missouri now, unfortunately, with my parents, because I'm here all the time. So why do we use, what do we use spinal anesthesia for? Well, we use it as a sole anesthetic when we can, because it's such a great way to perform anesthesia. We don't have to instrument the airway. We don't have to do a lot of different things when we do that. So we use them for lower abdominal surgeries, such as C-sections, hernia repairs, things like that. They are absolutely perfect for hemorrhoid cases because most patients who have hemorrhoidectomies are actually in the prone position on their stomachs. You put just a small amount of local anesthetic into the lumbar area. You have them sit there for a few minutes, and the area gets completely numb. They just roll over on their stomach, and the surgeon can do whatever he wants to. If we could just talk the surgeons into realizing that it is a fantastic anesthetic, I think we'll have won. And then finally, last but not least, we can do them for the lower extremity cases, hips, knees, things like that. Why do we use epidural anesthesia? Well, we can use epidural anesthesia as the sole anesthetic. I don't see that done a lot, but you can certainly do that with lower extremity surgeries and lower abdominal surgeries. What we use more often than not here at Legacy Good Sam is basically a way to, it's an adjunct to general anesthesia, and the epidural remains in place after the procedure so that when the patient goes to the floor, they're still getting local anesthetic through the epidural and are getting significant pain relief from that. And then last but not least, we certainly use it every day for control of labor pain. When would we not use either one of them? Well, absolute contraindications to neuraxial anesthesia include patient refusal. If the patient says, I don't want it, you can't do it, bottom line. If the patient has infection at the site of the needle puncture, we would not do it. Increased intracranial pressure. Anytime anybody's got intracranial hypertension, it's not a good modality for anesthesia. And last but not least, any bleeding issues that patients may have. Anybody have an idea why that would be?
You can bleed into that space and you can't see it.
What do you call that? You're right, absolutely. Usually we call it an epidural hematoma, and that becomes a surgical emergency. And if you suspect that in one of your patients, the first thing you should do is notify the provider involved. They need to get an urgent MRI to get an idea of what is going on back there. And the sooner they get to surgery, the quicker they can have recovery of motor or sensory function. Because if it's not quick, it can be quite devastating. When would we not necessarily not ever do it, but we would certainly it would certainly give us pause. Well, these are times when I would certainly consider a different mode of anesthesia. Anytime a patient is septic, bacteremic, even though there's a small risk of taking that infection and introducing it into the neuraxis, it's still not a good idea. Patients with chronic neurologic disease such as multiple sclerosis, spinal anesthesia has actually been shown to reactivate multiple sclerosis, things like that. Patients that have cardiac disease with low ejection fractions, whose hearts just don't work well, it's not a good idea because spinal anesthesia certainly lowers the blood pressure, and that can be devastating to patients with cardiac disease. And then last but not least, abnormal coagulation. Anybody that's on low molecular weight heparin, things like that, Plavix, for the same reason that we just talked about, epidural hematoma could occur, and that's not a good thing. Anybody a Dave Matthews fan? That's the Columbia River Gorge. You can see it's absolutely beautiful. I'll show you my seats here in a minute. Side effects. Well, for spinal anesthesia, being on the floor, you're not going to see these side effects per se. These are immediate side effects that we see in the operating room, so this is not so important that you know, but there are certain things that we have to really be mindful of in the operating room. Neurologic complications, nerve damage. When we put that needle back there, once it goes in the back, we can't see where it's going. So if there's a nerve there, there's a potential for damage. It's very rare. I've never seen it. But if it does happen, it's usually transient. They get a paresthesia that they have for a little while and it goes away, but there's a potential there for permanent damage. So that's something that we really have to watch. We've mentioned this before. Hypotension is a huge problem with spinal anesthesia, especially in patients who have cardiac disease. So we really have to be ready to treat it. It's from basically decreased venous return. It's also due to just a decrease in the systemic vascular resistance. So how we treat that? Well, there are things we can do. We can put the head down, increase the venous return. We can give fluids, and we can also give sympathoma medics, which actually work to increase the blood pressure. This is something that we don't see very often, thank goodness. Bradycardia and asystole. It's usually in the younger, healthier patients that get spinals. And there are some physiologic reasons for this, but just know that it can occur and be ready to treat it. Anybody have an idea of whether you would put the head up or the head down? Because if you've got a spinal and you put that medication into the cerebral spinal fluid, if you put the head down, you're going to get what's called a high spinal, but you're going to be increasing your venous return. If you put the head up, the medication's going to be going down, but you've decreased your venous return. Anybody have an idea which would be treatment of choice?
Head up fluids.
What's that?
Head up fluids?
It would be head down fluids, just because you're right, the medication would go up, but you've got to increase that venous return. That's the most important thing. You got to get the blood flow back to the brain. And that local anesthetic, that will go away. It may take some time, but it will go away. Other complications with spinal anesthesia, since we're actually putting a hole in the dura, patient can get a post-dural puncture headache. And these are basically described as the worst headache you've ever had in your life. It happens, 12 to 48 hours, post-dural tear or post-dural puncture. And there are things we can do to treat it. Usually, when you get a patient that comes in, they feel fine in the supine position, but they sit up and they're absolutely dying. And that is usually the only hallmark that I need to know. A history of the spinal and pain with being in the upright position is basically a post-dural puncture headache. So then what you can do for that is you can treat it conservatively, which is how I usually do it, or you can do more invasive treatments, and that would be with an epidural blood patch. And what that basically amounts to is taking 18 to 20 cc's of the patient's blood and actually getting into the epidural space, not the dural space, injecting that local anesthesia, injecting that blood. And what the theory is about a post-dural puncture headache is that there's a leak. Because we've put a hole in the dura, there's a leak of that fluid. The fluid works to support the brain. When it's coming out of a hole that you've made, there's not that support, and that pressure, that downward pressure, gives just that horrible headache. And that blood, what we think the blood does, is it clots that hole, and also provides kind of a pressure against that hole, and patients actually immediately feel better. So, but there are risks to that procedure too. You put an epidural needle in, there's another chance of doing exactly what you're trying to avoid. So that's why I tend to go with conservative treatment, which is basically bed rest, fluids, analgesics, and caffeine, as much caffeine as you can get your hands on. Caffeine actually works to constrict the cerebral vasculature and takes that pressure off of the brain. A high spinal we've kind of already talked about. That's just something you have to be ready for. What basically happens is because the spinal decreases the systemic vascular resistance, decreases the venous return, the respiratory centers in the brain become ischemic. They don't get enough blood flow in the medulla, and so they can become apneic and even unconscious. I've seen this before. It's kind of scary, but what you have to do is you have to go back to your ABCs: airway, breathing, circulation. You support those things, the local anesthetic will wear off, and usually the patient's fine. Those are my seats. I think he's looking at my girlfriend, I'm not for sure. So these are the complications you guys are going to see more often. Well, you probably won't see this first one so often, but these are the more complications that you're going to see. Failed epidural anesthesia. Like I said, when I put that needle in your back, or in a patient's back, I shouldn't say your back, I don't know where the catheter is going. If it's going off to the right, or if it's going off to the left, or if it's staying right in the center where I want it to be. And so sometimes a patient gets, I think the most common complication I have with an epidural is that a patient will get relief on one side of their body and not the other. And there are things that we can do to fix that. I mean, we can manipulate the catheter, but the bottom line is usually you just have to redo it. And every time you redo it, the risks are the same. So you're doubling your chance of any complication. Epidural hematoma, we've already talked about. It's a surgical emergency. You got to get an urgent MRI. If you suspect this in your patient has back pain that's new onset, it's coming on quickly, let us know. This is something that we really have to take care of. Usually it happens when we get a bloody tap, meaning that we cause vascular injury with placement of the needle, but it can occur just spontaneously. It went in just fine, but for some reason, they get it. We've already talked about the wet tap, which is the post-dural puncture headache, just another name for it. What are some complications? Other complications of epidural anesthesia, I'm really not going to spend any time on these, but hypotension, neural injury, those types of things. Anybody know what this is? It's a very famous picture. Nobody?
It's the Orioles.
Anybody ever heard of Voyager? Voyager 1 and Voyager 2? They were basically not satellites, but the space probes that NASA sent out in 1977, and they sent them out to basically explore the reaches of our solar system, just our known solar system. And in 1990, a guy named Carl Sagan, anybody heard of Carl Sagan, talked NASA into, as Voyager 1 was about 4 billion miles away from Earth, talked to NASA, and he had to really ask them nicely to have Voyager turn the camera around as they were leaving the Earth and take a couple pictures. And do you see that pale blue dot right there? That's you. So I just think that's kind of neat. Our troubles are so important. So talking about trouble, this is kind of this is the meat of the talk. So if you have questions here, this is the stuff you guys are going to see on the floor. So for a spinal, you're going to see two different problems. Basically, there are other things that can happen, but these are the two you're going to see. You're going to see patients with respiratory depression, and you're going to see them with itching. So what do you do for respiratory depression? Well, you're really just going to have to check respiratory rates every hour for the first 24 hours. We see that more with intrathecal morphine, which is called Duramorph, than we do with fentanyl. And the reason for that is that Duramorph is hydrophilic. It mixes with the cerebral spinal fluid, and in the way that the circulation of the cerebral spinal fluid acts, it tends to make its way up, and it can get into the respiratory centers and really delay respiration. The time that you really need to be aware of this is 12 to 16 hours post placement of the spinal. So if you, and usually these are right in the middle of the night, which is just great. So patients don't like to be woken up, but you don't actually have to wake them up. Just go in and see how they're doing. And after that 24 hours, everything is usually fine. The thing that drives patients crazy and nurses too is this itching, this pruritus. And this is actually kind of interesting. I'm sure you all have used Benadryl, and I'm sure some of you have used Narcan. But the new thinking is that there's a brand new study out there that says ondansetron works every bit as well. So I'm glad to see a few people here. So share that with your friends, share that with the nurses. Actually, it's every bit as effective as Benadryl. So, and there's not the side effects. So my advice would be to use Benadryl, and if that doesn't work, go to Zofran, because the two of them together can actually be synergistic. So that's a new finding. For epidurals, so who gets epidurals? People that, from post-surgical patients that get epidurals, are patients that have had major surgery, belly cases, vascular cases, things like that. So if you get a patient that has an epidural that drops their blood pressure, don't assume that it's the epidural. If you want to look like a star, find out if it's blood loss, and because that's something that can save a life. And don't just assume it's the epidural. Go check out your patient. Look at the ins and outs. Ask them if they've got how they're feeling. Are they short of breath all of a sudden? Things like that. If it's not that, you certainly want to have parameters that you're going to treat the blood pressure with. I think most of the orders that we write have ways to modify the blood pressure if the blood pressure does fall. Fluids, ephedrine, phenylephrine, those types of things. Nowhere that the surgeons, the physicians want the blood pressure. If you rule out blood loss, if you rule out any other type of thing, you think it is the epidural, then let us know. There are things we can do. We can slow that epidural rate down. We can take it out, but really exhaust those other things first, because those are important things to pick up. Know that positioning can affect the spread of the local anesthesia, the local anesthetic. Like I said, I don't know where this catheter is going. If it's going off to the right, the left. This happens all the time in obstetrics. The patient will get complete relief on the left or the right and have excruciating pain on the other side. Well, what do you do in that situation? Well, instead of redoing it, you can put them on that opposite side and get that gravity to work on that local anesthetic to get it to cover those areas. So just know that you can do those types of things. For every patient that you get with an epidural, look and see if that patient's getting blood thinners, heparin, low molecular weight heparin. Most of us are aware of those things. Most of the anesthesiologists, it's one of the things that we do, but it never hurts to have another set of eyes on that, so that we know when we take it out. It has to do, the importance of this is to have to do with the timing of taking it out. Because if you take it out too soon, when a patient's been on low molecular weight heparin or things like that, they can get an epidural hematoma. So we really need to watch that. So if they're on blood thinners, look, be aware of it, let us know. Know that epidural infusions, just like spinals, have narcotics in them. Fentanyl, sometimes morphine. I think fentanyl is the one you're going to see more often here, but know that you can get respiratory depression just like you can with spinal anesthesia. And the ones you guys should really pay in mind are the elderly who are on these things, and patients that are on high doses of local anesthetics. Somebody wanted me to talk about the difference between ropivacaine and bupivacaine, because most of the solutions that we use in the hospital are either bupivacaine or ropivacaine. Anybody know the fundamental difference? They last about the same amount of time. Bupivacaine is much more cardiotoxic. I tend to not use it if I don't have to. It's certainly safe, but if it gets intravascular, it can really cause some damage. And the reason for that is that it basically irreversibly, not irreversibly, but it very tightly binds the sodium channels in the heart. And that can make a patient basically go into ventricular fibrillation, heart failure, those types of things. And before the advent of intralipid, anybody heard of intralipid? Patients would, if this went intravascular, patients would have to go on bypass in order to save their lives, because it's just not gonna get any better. Now we have this, I don't know who figured it out, it's kind of interesting, but there's a solution that we can give intravenous if bupivacaine goes into the vascular space that actually binds up the bupivacaine, takes it off of those sodium channels, and can restore appropriate circulation, appropriate heart function. Be mindful of the dressings. Make sure that they're always clean, dry, and intact. If they're not, let us know. We'll take care of it. You know, look for leaking, those types of things. And those are really what I want you to know about, you know, troubleshooting on the floor with spinals and epidurals. If you guys have problems during the day, and that by day I mean up to 5 o'clock in the afternoon, call the AOD, which is the anesthesiologist of the day. They'll come and take a look at it, help you out, whatever they need to do. That's 39294. I don't have that phone today, thank goodness. At night, we always have an anesthesiologist in-house for L&D. They don't always have a phone, but you can always get a hold of them just from 37333. That's the front desk of L&D, and I can put you in touch with that person. And that's pretty much it. And I did this one for you guys. Any questions about anything? Any questions that I didn't cover about something that you had? Yeah.
In the old days, we used to aspirate the epidural to make sure before we gave a bolus. And I know one of the doctors said you barely put any pressure on it. If you do it hard, you can move the tip. And do we ever aspirate anymore?
We do, and that's probably something I should have mentioned. I'm glad you brought that up. Every time you give a medication through an epidural, always aspirate. The reason for that is twofold. The catheter can move, and it can move into two basic spots. It can move into a vessel, and it can move into some of those catheters can puncture the dura and get in directly into the CNS. So that's a great question. You do, if it is in either of those places, if you pull back, you're gonna see blood. If it's in a vessel, let us know. And if you get clear fluid back that is coming back rather quickly, not very slowly coming back, but coming back quickly, it indeed could be in the dura, and that could be CSF. And so if you give a big old bolus of local anesthetic into that space, that could be problematic for the patient. That's a good question. I don't think a lot of you guys are going to be actually pushing something through an epidural, but yeah.
Scott, one of the things with the new orders for epidurals, in compared to old days, now we can only give 300 of fluid bolus if there's a low pressure.
Mm-hmm.
We can no longer give ephedrine like we used to be able to. So that's just FYI for whoever's on the floor managing that.
Okay.
Used to be we could give more
Ephedrine.
we could give up to 500 of fluid and ephedrine.
Hmm.
And we would give it IV and IM, but it's a
I wonder
call
why
to
that's
the doc
changed.
now.
I wonder why that's changed. Because on OB they can do that. I guess the patients are younger, healthier, but they may have been assuming that some of these patients are a little bit older and have more comorbidities, things like that. That's good to know.
Can you speak to dermatomes a little bit?
What would you like to know?
Well, the best way to assess dermatome level,
Um,
and what all that means?
Yeah, that's not something I usually get into. I'm happy to talk about it, but for me, an epidural is either working or it's not. A spinal is either working or it's not. And you can assess dermatomes, and you can do it by there are a million different ways to do it. You can do it with a toothpick. You can do it with a blunt. Actually, you can take the tip of the cap of the needle off, and those types of things. You can do it with ice. And what you would do is you would just ask the patient where they feel different as you go down the body. I think it's probably more important for you guys than it is us, and that's a good question, because a lot of patients that go to the recovery room, the spinal has to start to wear off, and so you have to assess those dermatome levels. But I think a great way that I do it on my patients in OB is I take some ice, and I ask, I'll put it on their shoulder, ask them what they feel, put it down to where wherever the surgery is or wherever you suspect that the dermatomal level is, and see if it feels the same. Usually that's one of those that